Good evening and welcome to the Rogosin Institute's webinar series about IgA nephropathy. Tonight's discussion will be about understanding the 2025 KDIGO Guidelines. My name is Jeffrey Silbersweig. I'm the Chief Medical Officer at the Rogosin Institute. And I'm pleased to introduce tonight my friend and colleague, Dr. James Chevalier. Dr. Chevalier graduated from the State University of New York in Buffalo School of Medicine and then trained in internal medicine and in nephrology at Weill Cornell Medical Center. In between, he took 1 year as a chief resident at what is now New York Presbyterian's Lower Manhattan Hospital. And subsequent to his fellowship, he joined the Rogosin Institute and has been with us ever since, and is currently the director of our Jack Dreyfus Outpatient Kidney Clinic, and is an expert, among other things, in IgA nephropathy. And so I'm pleased to introduce Dr. Chevalier tonight to talk about KDIGO Guidelines. Take it away, Dr. Chevalier.
Thank you, Jeff. So the first question that I got asked is, what is KDIGO? It does stand for Kidney Disease Improving Global Outcomes, but the point is that these are the international guidelines written by experts in order to best treat IgA nephropathy. So I will share my brief disclosures, and then we'll start with the outline. So why are we talking about IgA nephropathy in 2026? Well, last fall, about 5 months ago at this point, the international guidelines were published. And ironically, they're already outdated, meaning that several medicines have been approved to treat IgA since these guidelines came out. So for tonight, I'm going to use my own updated guidelines, which include all of the medicines which are now FDA approved to treat IgA nephropathy. All right, so throughout the evening, we will have many questions in order to have participation from the audience. Please feel free to answer in the chat, and we can all follow along together. So we'll start with the first question. True or false? As long as a person suspected of having IgA nephropathy has less than 1 gram of protein in the urine, they are at low risk for kidney failure and don't need a kidney biopsy or medication to suppress the immune system. Go ahead and answer in the chat, true or false. So it looks like we pretty much have a unanimous consensus. The correct answer is false. All right, so IgA nephropathy is not just benign hematuria, a term that unfortunately was used to describe IgA nephropathy and has been associated with the disease. So on the left, we see the old story, which was mostly in 2021 guidelines and earlier, where people just said it's benign hematuria. Just watch and wait. Don't do too much. If you get them under 1 gram with supportive care, you're good. Don't worry about it. No biopsy, no immunosuppression. But on the right now, we can see the new story. We now know that IgA is a serious and progressive disease, and that most of the people diagnosed with IgA in the United States do have a risk of kidney failure at some point in their lifetime. So what do we need to do? We need to act earlier and more aggressively. And rather than just starting with these supportive measures, we're going to use a 2-prong approach, as we're going to see later. All right, so let's talk a little bit about the old guidelines and the new rules. So the old guidelines were the last updated in 2021 prior to the new 2025 guidelines. Now, if you look at my updated guidelines, we're going to start at the top. What does that mean? Progressive or at risk of progressive kidney function loss. Well, luckily, these guidelines have helped define that. And one of the reasons that's important is just about every medicine that we're going to see has been approved by the FDA to treat people with IgA nephropathy who are at risk of progressive kidney function loss. So now we have to define what that is. True or false? The 2025 IgA Nephropathy Guidelines state that all patients with IgA nephropathy are at risk of progressive kidney function loss and kidney failure. True or false? Go ahead and answer once again in the chat. So this one looks a little bit more mixed, but the answer is actually false. Not everyone with IgA nephropathy is at high risk. We're going to see who is and who isn't in a second. So as I said to the doctors in training when I taught them about this, na 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 na, na 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 na, hey, 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 goodbye 2021 guidelines. We're going to start with 2025. All right, so number one, people who have a gram of protein in the urine are not low risk. The old way on the left says no biopsy if you could just use supportive treatments and get them under a gram. We thought that by getting under a gram of protein in the urine by any means necessary meant low risk. No need for kidney biopsy, no need for immunosuppression. We now know that anyone who has 500 milligrams a day, half a gram or more, and has possible symptoms of a glomerulonephritis like IgA nephropathy should be biopsied, because we know that half a gram or more of protein in the urine is what puts people at high risk for that progressive risk of kidney failure. Those are the people that we need to be more aggressive with. So now we have to point out that just because a nephrologist may get someone with IgA nephropathy to not have kidney failure during their career, that's not really a win for the patient if the person's second nephrologist is the one that has to start them on dialysis or get them a kidney transplant. Our goal is now to try to diagnose IgA earlier when there's only half a gram, not when there's more than a gram. And we want to start more aggressive treatments early so that the lifetime chance of kidney failure decreases. So once again, on the left, on the top, you can see that we used to give supportive care for 3 to 6 months, like some medicine and some blood pressure control. In the new 2025 guidelines, we don't just use supportive care first. It's now a two-pronged approach of both medicines that suppress the immune system and our supportive care. We now no longer use less than a gram. We now want less than half a gram of protein, ideally less than 300 milligrams a day. Where did this come from? Well, thanks to newer studies, we now know that people with more than 500 milligrams of protein in the urine are actually the ones who are at high risk for progression to kidney failure. This is a much more aggressive and protective target that hopefully will diagnose earlier and save more kidneys. All right. But Chevalier, where did they get 0.3 grams per day of proteinuria from? Well, the answer is it has to do with normal aging. So we know that every person loses a little bit of kidney function through normal aging alone. If someone has a lot of protein in the urine, like people with IgA with a lot of protein in the urine, their kidney function gets worse faster. Oops. Their kidney function gets worse faster than just normal aging. We want to try to get the loss of kidney function back to the normal aging line. And how do we do that? Well, if we get the protein in the urine less than 300 milligrams a day, we get the patients back on this normal aging line. And we can't do any better than that. We can't reverse normal aging. So that's why the 300 milligrams a day of protein is now called complete remission and is our ideal goal. All right, so in order to talk about the guidelines and the medicines that treat the IgA, we need to do a little bit of a review about our 4-hit model. So the new medicines all kind of treat IgA by acting on one of the different parts or one of the different problems that have to happen in order to cause IgA nephropathy. So starting from the very beginning, if we take the two terms, IgA and nephropathy, IgA stands for immunoglobulin A, an abnormal type of this antibody that we should be making to attack infections like bacteria and viruses is accidentally made wrong. Because this antibody is made wrong, our own immune system makes antibodies to attack these bad antibodies. What does nephropathy mean? Well, it means damage to the kidneys. The damage comes from these clumps of antibodies, these antibodies from the immune system attacking these galactose deficient IgA antibodies. And when these clumps of antibodies called immune complexes get stuck in the glomeruli, the kidney filters, it leads to inflammation, which can eventually cause permanent and irreversible damage if we don't stop it. Now, like I was saying before, there's 4 hits or 4 abnormal steps that must happen for someone to get IgA. Number 1, the person must make the bad galactose deficient antibodies. Number 2, the person's immune system must make antibodies that will attack the galactose deficient IgA antibodies. The immune system antibodies and the galactose deficient IgA antibodies stick together in clumps that we call immune complexes. These immune complexes travel through the bloodstream and eventually get stuck in the small blood vessels in the filter of the kidney called the glomerulus. This causes inflammation, which can lead to permanent and irreversible damage if we don't stop IgA at one or more of these 4 steps. So let's be a little bit more specific. Hit number 1 is when a person accidentally makes these bad antibodies. Something, usually an infection, triggers the body to make antibodies. Some of them are good and attack the virus or bacteria, and some of them are these bad galactose deficient IgA antibodies. We know that not every infection causes every problem. But once these antibodies are made, it's a problem. So somebody asked in the chat what makes it wrong. The person with IgA is born with the ability to make these bad antibodies. There are people who are born with this ability that never actually make the bad antibodies because they're never exposed to the right trigger. Other people with the ability to make these bad antibodies are exposed to their specific trigger and they make the antibodies. Some people only make the bad antibodies when they're exposed to the flu, but not COVID. Some people only make the bad antibodies when they're exposed to strep throat, but not to the flu. So each person is unique and has his or her own trigger as well. All right, hit number 2. The person's own immune system comes across these galactose deficient IgA antibodies in the blood, recognizes them as abnormal, and makes antibodies that will attack the bad galactose deficient IgA antibodies. When the immune system antibodies and the galactose deficient IgA antibodies stick together, they make clumps called immune complexes. The complement system, which we're going to talk about a little bit later, also joins in these clumps or immune complexes. They travel through the bloodstream and eventually get stuck in the glomerulus, the kidney filter, which leads to the inflammation and eventually permanent damage. So just to summarize, hits 1 through 3, galactose deficient IgA antibodies are made. The immune system makes antibodies to attack those galactose deficient IgA antibodies. Together, these make clumps, these immune complexes, which travel through the blood and eventually get stuck in the kidney glomerulus. When they get stuck in the glomerulus, like you can see here, it leads to inflammation, these purple squiggles. That causes holes in the kidney filter and allows things that should not get through the filter, such as protein, to leak through the filter because of this inflammation and end up in the urine. Protein in the urine can lead to more damage to the kidney filter, more protein in the urine, more damage, like a vicious cycle. So we want to work on all of the hits, including this one, in order to decrease the stress on the kidneys and decrease the chance of kidney failure in someone with IgA. Right. So the question becomes, why act now? Every IgA nephropathy flare-up is like a punch to the kidneys. All right, so let's come back to another true-false question. Treating IgA nephropathy when the blood creatinine is normal can save more kidney function than waiting until the blood creatinine gets worse. True or false? So once again, I think that everybody's going to get this one correct. The answer is in fact true. That's the whole purpose of KDIGO 2025, is to try to diagnose earlier when the labs are still normal and there's good kidney function. So unfortunately, IgA is kind of a quiet disease. Many people don't come to medical attention and have the kidney biopsy to diagnose IgA until they've already lost significant kidney function, say 40% of their kidney function or more. If we look at this diagram, this triangle here is like kidney function and the amount of kidney function that we still have left. Over here is like 100%, and down here is 0%, where you might need dialysis or a kidney transplant. If we wait to do the kidney biopsy here, you can see that we've already lost this much kidney function by the time we even do the biopsy. At this point, this is the only window we have to save this much kidney function. People often ask me, Chevalier, what's your goal when you diagnose someone with IgA? And the answer is, I'm trying to save whatever kidney is still functioning normally at the time of the biopsy, at the time of the diagnosis. Now, what does KDIGO 2025 want us to do? We need to take this kidney biopsy and move it all the way back here. If we can diagnose earlier when there's more kidney function to save, perhaps 90 or 95% of the kidney function, the window of opportunity to save the kidney function is much greater. By diagnosing earlier and acting more aggressively at the beginning, we hope to save more of this kidney function than we can with a late diagnosis and the previous supportive treatments only at the time of diagnosis. All right. Why do people have such advanced kidney disease at the time of diagnosis? So if you look on the side here, you can see that about 61% of people have a kidney function, a GFR of less than 60 at the time of diagnosis. That means that we don't have a lot of kidney function left to save, even with the best medicines. Why does it take so long to diagnose somebody? Well, number one, young people with no symptoms don't always go seek medical care right away. Number two, primary care doctors and others, urgent care, ERs, often see this blood and protein in the urine, assume it's an infection, and give antibiotics. Number three, people with blood in the urine are often sent to a urologist to look for a bladder issue or a kidney stone. And if the urologist doesn't find a urology issue, they often think that they're cleared and never see a nephrologist. Women are often told that it must just be menstrual blood. Check it again later and we won't do anything now. What can we do to try to diagnose earlier? Well, on the left, we are discussing ways that we can work with primary care providers and others to try to make alerts that suggest the person might have IgA or another glomerulonephritis, and to try to get that diagnosis earlier. Across the world, many countries screen with urine analysis at some point in a young adult's life. In many of the Asian countries listed there, screening is done in elementary and middle schools. In countries where there's mandatory military service, there's also a urine sample done prior to the person entering military service. This is probably a cost-effective way to screen for IgA, and in the United States, maybe we should consider a urinalysis as a requirement when kids go to college. All right, so we'll go back to our true-false. In a person with biopsy-proven IgA, getting to less than 1 gram of protein in the urine essentially eliminates the risk of kidney failure. True or false? Go ahead and answer in the chat. Good. I hope I'm reinforcing that the 1 gram based on the 2021 and earlier guidelines is no longer our goal. It's no longer good. It's no longer safe. New data shows us that even proteinuria that we previously considered at goal in 2021 and earlier is actually a really big deal. So here's the KDIGO guidelines. So prior to 2023, when a landmark trial came out, everything was about less than 1 gram. Since the 2025 KDIGO guidelines, as we're reinforcing over and over and over again, less than 0.5 gram is the goal, with a preference for less than 300 milligrams a day. Anyone with more than 500 milligrams of protein in the urine is at high risk of kidney failure in their lifetime. It might not be this year, next year, or even this decade, but people with IgA are often diagnosed young, in their teens, 20s, or 30s. They have many years to live. So we want to treat them early and treat them aggressively. All right, this is the trial that changed the 2025 guidelines. This is the trial that changed the 2025 guidelines. It was called the RADAR study. It was a registry of people in the United Kingdom who had IgA and some other kidney diseases. I know that the letters are in the wrong order because it stands for Registry of Rare Kidney Diseases, but I think we can still remember RADAR. Of all the people that were in the registry, almost 2,300 had IgA nephropathy. Prior to this study, 1 gram a day of protein in the urine was considered goal. But during this trial, they saw that people that got to 0.5 gram to 1 gram, previously considered goal, 30% had kidney failure in 15 years. 20% of people still reached kidney failure in 15 years, even if they were less than 0.5 gram. And this is why KDIGO changed the goal. Now, somebody asked why the people less than 0.5 gram did still reach kidney failure. And the answer is, even if you get the people to goal, if they start at a very low kidney function, for example, 25% or lower, and they lose 0.5% to 1% per year with normal aging, these 25 and 30-year-olds will still reach kidney failure in their lifetime. And people who have low GFRs, low kidney function at the time of diagnosis, still can reach kidney failure even if they have the perfect treatments. That's the whole reason that we want to diagnose people earlier, when they still have 80 to 95% kidney function, not when they only have 25% kidney function. All right, so there is an infamous heat map that also comes from this trial. Now, As we said before, IgA is usually diagnosed in people in their teens, 20s, and 30s. You might think of 3 mLs per minute per year as being somewhat slow loss of kidney function, but it's not. Anybody that's diagnosed before the age of 40 and loses 3 mLs per minute per year, which is approximately, you can think about it as percent kidney function, will have kidney failure in their lifetime. So if someone is diagnosed with a kidney function of 60% at the age of, say, 30, and they lose 3% every single year, they will have kidney failure in their expected lifetime. Even people diagnosed in their 40s and younger who are only losing 1% a year still have a 40% chance of kidney failure. This is the reason that the new 2025 guidelines recommend that we get the loss of kidney function to less than 1% per year. The million-dollar question is, how do I know? What is their kidney loss when I meet them the first time? How do I know what it is in the first year or two? I can't calculate the percent kidney loss. What am I supposed to do? Well, the answer is proteinuria. The protein in the urine is the only reliable thing that predicts kidney failure in the future. If you get the protein in the urine less than half a gram a day, but preferably less than 0.3 or 300 milligrams a day, that's when you get back to that less than 1% per year loss. That's why we call 300 milligrams complete remission and getting you back to normal aging. Once again, if the person's kidney function is only like 20% at the time you get diagnosed, you could easily have kidney failure from normal aging alone, even with the best treatments. That's why KDIGO is about diagnosing earlier and treating aggressively to get to 300 milligrams or less as fast as possible. Now, there was sort of one criticism of the RADAR trial. Because it was done in the United Kingdom, 77% of the people were white. So there was a Kaiser Permanente study done in California with a much more diverse US population, as you can see there. The point of the story is that they found the exact same findings as the RADAR trial in the United Kingdom. You really do start to get a risk of kidney failure after about a half a gram. So this confirms that the KDIGO 2025 guidelines of less than 500 milligrams with a preference for less than 300 is really the right target. All right, diagnosing and defining the risk. So now we're going to get into the nitty-gritty of what these guidelines say. All right, we have another question in the presentation. Go ahead and answer in the chat. This one is multiple choice. What is the primary way that doctors confirm a diagnosis of IgA? Well, it looks like I've got some smart people on the webinar tonight. You are all correct. A kidney biopsy is the only true path to diagnosis. All right, so KDIGO 2025 says, number one, do a kidney biopsy. Do it at 500 milligrams a day of protein in the urine if they have any symptoms or you're even considering the diagnosis of IgA or a different glomerulonephritis, meaning inflammation of that filter, inflammation of that glomerulus in the kidneys. Rule out secondary causes, things that can cause IgA antibodies that would then deposit in the kidneys. We're going to talk next about the MEST C-score and this international IgAN prediction tool, which help calculate the aggressiveness and risk of the IgA. I will talk a little bit about how I don't use the international IgAN prediction tool that much when we get to that slide. All right, the MEST C-score is kind of like a report card for your kidney biopsy. There are 5 letters that you can see there. You get a number after each of those 5 letters. Just like golf, you want the lowest number. So zeros are good. I don't think it's so important to know what each of the letters stand for, but we probably should point out that the more numbers you get, or the higher the sum of the numbers, in general, the more aggressive the IgA is. Now, we're going to talk a little bit more on the next slide about how the different letters might mean things a little differently. We should also point out that if you had your kidney biopsy before 2009, you might not have had this in your report. And if you got your biopsy before 2016, you might not have had the C in your report. All right. Once again, the higher the sum of the numbers, the more aggressive it is. In general, the 7 is the most aggressive, and getting a 0 is the least aggressive. Now, I do think that there are some more specifics. The E and the C represent active inflammation, active attacks from the immune system. Once you see that the E and C are positive, more than 0, you're on a ticking clock to try to stop that damage before it becomes permanent damage. People who have E and C are a little bit more likely to have their creatinine come down or the protein in the urine come down with immunosuppression. The S and the T represent more scarring, the M to a lesser extent. S and T scarring means that at some point there was E and C activity that eventually ended up scarring and became the S and the T. Every number that's not a 0 makes things worse. There are some studies who have tried to correlate these letters to the chance of kidney failure later on. The S and the T and the C, especially if they're a 2 in the T and the C, strongly recommend or strongly suggest the chance of kidney failure later on. Now, some people think that the M1, E0, S1, T2, C0 down there is the worst of all because it's all scarring. Immunosuppression is less likely to reverse the numbers, and it usually means that it's the most aggressive and most likely to go on to kidney failure. Now, I know that there was a question about having both IgA and a second diagnosis. The short answer is yes. Unfortunately, many people in the United States have a little bit of damage to their kidneys and their kidney filter from things like obesity, diabetes or high blood sugar, high blood pressure, and then those things could cause some protein in the urine along with the IgA nephropathy. Rarely you can get 2 different autoimmune diseases. Usually it's one of the common things in the United States that stress the kidneys, like diabetes, high blood pressure, obesity, in addition to the IgA. All right, last but not least, this is like a report card. Zeros are good. We want to see zeros. Ones represent damage. Twos represent severe damage. Now, the KDIGO 2025 says only a fresh kidney biopsy and a fresh MEST C-score really guides you on what you might choose as your treatment in broad strokes. Because in all of the research trials for IgA medicines, the kidney biopsies were more than like a year and a half old on average, you can't really say that the biopsy from a year and a half ago represents today's activity in the kidneys. All right, the International IgAN Prediction Tool is basically a calculator where you plug in variables, including demographics, labs, blood pressure, biopsy results, etc., and it predicts the chance of kidney failure or 50% decrease in kidney function, which is basically what it's calculating for most people. You can use it up to 2 years after the biopsy, and then it gives you about a 5-year window. Again, I don't know how helpful it is for me to tell people their chance of a 50% chance of decreasing kidney function, but I do think that I go through the individual components of the tool and explain why they are important. All right, so what are these new goals? So, as we've said many times and will continue to reinforce, 0.5 gram with a preference for less than 0.3 grams. Why so low? Well, number one is time. People with IgA are often diagnosed between 18 and 40. So even slow damage adds up over the course of 40, 50, or 60 years. We now know, thanks to studies where they followed people with IgA, we know that even low levels of protein in the urine can increase your risk years or decades later. We don't want to wait and watch the loss of kidney function. We want to use the proteinuria as our goal to treat aggressively right at the beginning. So one of the most important parts of these guidelines is what's currently in the red box. I feel like a lot of people are all excited to talk about the new medicines and whatnot, but they kind of overmiss this statement. Two-pronged approach simultaneously, both decreasing the stress on the kidneys in general on the right and using medicines to lower the galactose deficient IgA on the left. Same time, right at the beginning. So once again, two-prong approach. Prong number one slows the loss of kidney function with general supportive or foundational care. Prong number two lowers the galactose deficient IgA. Once again, start at the same time at the time of diagnosis. Do not use supportive care first for 3 to 6 months like we did prior to the 2021 guidelines. All right. Simultaneous is the most optimal care. All right. Now I know what everybody wants to do is to talk about the medicines. So let's start. Another multiple choice question. Which of the following is considered a supportive or foundational treatment for everyone with IgA nephropathy? Go ahead and guess your letters. And I did see a question about multiple biopsies. In IgA nephropathy, we're a little less likely to do multiple biopsies. Usually we know it's IgA nephropathy that's causing the kidney issues. And if we think someone's having a flare-up, we often treat it. Sometimes when we might repeat a biopsy is when we're trying to figure out or to tease out, is there activity of the immune system attacking the kidneys, in which case we should give more medicines to suppress the immune system? Or is this just old scarring left over from the old attacks, in which case we don't really need as much immunosuppression. We need as much of the supportive or foundational care as we can get. You were all correct. The answer was C. Now, there are some people, going back to the question, that use blood in the urine as one of the things that indicates flare-up, including immune system activity. And that can be one of the non-repeating the biopsy ways of telling if we should use immunosuppression or not. So the question in the chat was about 1 gram with steroids and with supportive care is less than 0.5 or 0.3. If you're at goal, we generally do not add additional medications. If the person is above the 0.5 grams or the 500 milligrams a day, we would add more medication. Now, getting back to the hematuria, the blood in the urine that I just mentioned, a lot of the medicines on the left side that lower the galactose deficient IgA did work even in people who did not have blood in the urine. So the idea of blood in the urine remains somewhat controversial in the world of nephrology. All right, lifestyle and supportive care. Generally low salt diet, exercise, quit smoking, and get the blood pressure now suggested to less than 120/70 if you can. The top number is more important. All right, now we're going to get into some of the exciting things, the medicines. So you'll see that KDIGO 2025 is the orange box. The RAS inhibitor, which is ACE or ARB, or DIRA, dual endothelin angiotensin receptor antagonist, which is the sparsentan we're going to see in a second, plus or minus SGLT2 inhibitors. After the guidelines were published, two more medicines down there, atrasentan and iptacopan, became available. So we're going to talk about those on the right side first. All right. Number one is the ACE inhibitors or ARBs. Many people are familiar with these. The ACE inhibitors usually end in pril, like the lisinopril, and the ARBs usually end in sartan, like the losartan. The ACE inhibitors have been around for 40-ish years, and the ARBs have been around for 25-ish years. We know that they treat high blood pressure and protein in the urine. You can combine them with an SGLT2 inhibitor, which is coming up on the next slide. It's another medicine that, is supportive to the kidneys. And a lot of the medicines that we're going to talk about initially make the creatinine go up. This does not mean that the kidneys are weaker. It means that these medicines are telling the kidneys to work less hard. People with IgA are not on a 3-month health plan. They're on a 30-plus year health plan. If these medicines make the creatinine go up for a few months, but then keep the kidney function better for years and decades, that's why we use them. And that's what the studies show. All right, now, prior to 2021, the only thing that we had for IgA nephropathy were ACE or ARB and steroids like prednisone. So in March of 2020, right before the pandemic really got going, this study ended, and it said that prednisone, ACE or ARB, blood pressure control, and statins were not good enough. The people were still not meeting the goals. Therefore, they said that we needed new treatments. Luckily, we got them. All right, here's another true-false question. SGLT2 inhibitors, dapagliflozin and empagliflozin, originally used to treat diabetes, are now recommended for people with IgA nephropathy and protein in the urine, even if they don't have diabetes. True or false? All right. You all got it true. I saw a question in the chat about blood pressure being what's called a U shape. Oops. And the question is sort of asking, is there a lower number below which you don't want to go? The short answer is yes. And the longer answer is it kind of varies from person to person. But the point of the story is that if a person takes so many medicines for blood pressure, that it makes their blood pressure so low that they become dizzy, weak, lightheaded with symptoms, you're probably not getting enough blood flow to a lot of your organs, like the brain or even the kidneys. If you don't get enough blood flow to the kidneys, then the kidneys can't clean the blood and the toxins in the blood will go up. So there is a too low of a blood pressure that also could hurt the kidneys and the other organs. So the question was about the dose of the SGLT2 inhibitors. So in general, I start with the starting dose. If the person meets their goal of less than 500 milligrams a day with their ACE or ARB plus the SGLT2, then I would stop and not increase the dose. If they have not met their goal, then I would increase the dose to the maximum dose. So once again, these medicines are advised to be added on to the ACE or ARB for people with IgA who have still not met the proteinuria goal. It does make the urine positive for sugar, for glucose. So when you see your UA in your patient portal and the glucose is yellow highlighted and red exclamation point, please do not get worried. It's because you're taking this medicine. All right, so there were two very large studies, one for dapagliflozin and one for empagliflozin. There were a lot of people with IgA nephropathy in the studies, and once again, these medicines did help those people. Now, there were a lot of older people in these studies because it wasn't just people with IgA nephropathy, it was people with all sorts of different causes of kidney disease. All right, so this is supportive medication number 3, sparsentan. So sparsentan is the last medicine that made it into the 2025 guidelines. It's that dual endothelin angiotensin receptor antagonist, or DIRA. It blocks angiotensin just like the ARB, but it also blocks another hormone at the same time called endothelin to provide sort of a double kidney protection. When the guidelines say start a DIRA or an ACE or ARB with the SGLT2, this is what they're talking about. The important thing says that you should know is that this medicine, sparsentan, is exchanged with your ACE or ARB. You do not take it in addition to your ACE or ARB because it's already doing the angiotensin part. You take it instead of your ACE or ARB. So it was evaluated in the PROTECT trial compared to an ARB, and it did a better job in lowering the proteinuria and slowing the GFR decline, the loss of kidney function. One of the things that I liked about this study is that it shared how many of the people got to the complete remission, 0.3 grams a day, which is the preferred target. A lot of the studies just say things like lowered by 30%, lowered by 40%, but it doesn't really tell me if the medicine got them to the KDIGO goal. Now, this medication does require checking liver blood tests every 3 months and is part of a safety program called a REMS program. Yes, this recording will be shared along with the first 2 webinars to the same YouTube channel where the first 2 are posted. Once you reach your goal, you generally have to continue taking the medicines. There are some people who are able to lower the dose of some of their medicines and stay at goal, but many people who get to goal with medicines need to stay on those medicines to stay at goal. The risk to the liver mentioned here. So the earliest medicines in this class caused liver inflammation. In fact, pretty much only the first medicine in this class caused liver inflammation. But because of that first medicine, every medicine in this class has gotten that liver warning initially. The other medicines in this class were able to get rid of the liver test monitoring after they had enough total patient years of safety. It's possible that this medicine might also be able to do the same in the future. I don't know if there's any level at which I would say the dip in the GFR is too much. Some people recommend 30% as maybe being too much drop in the GFR, as being too much. But I actually would try to hold out and be brave and keep going because the 20 or 30-year benefits greatly outweigh the 3-month change in the GFR. And yes, elevated liver enzymes, the blood tests, is what liver inflammation means. All right. Atrasentan is a new medicine that was approved by the FDA after these 2025 guidelines were published. This medicine only blocks the endothelin. So unlike the sparsentan, the atrasentan gets added on to the ACE or ARB. You do not exchange it. All right. Atrasentan was evaluated in the ALIGN trial. Once again, it lowered the protein more than the placebo group. They just published their 2-year data on the GFR, or loss of kidney function. Currently, this medicine has accelerated, or what you might call preliminary approval, based on lowering the proteinuria, and it's waiting for its full approval. So whoever asked about the safety program for sparsentan, atrasentan did not get a REMS program because it had a different research trial in diabetics. It didn't get approved to treat people with diabetes, but because it had so many patient years of safety, it was not required to have the REMS program, the safety program. All right. In autoimmune disease, it's not really the antibody, but the inflammation that causes damage. All right, we're going to go to hit 4, but there's a couple more questions in the chat. So GLP for kidney protein. In people with diabetes and kidney disease, we know that the GLP-1 is helpful. It's possible the GLP-1 is helpful in diabetic kidney disease because it treats both diabetes and obesity, which stress the kidneys. We believe that there is a benefit, or there might be a benefit to people without diabetes and without obesity, but it has not yet been proven. So the blood and the urine in general, we're happier when it's lower, because we think that might be less inflammation from the immune system attacking. We are going to talk about the genetics of IgA in a second, so I'm going to save that question for the genetics section. So as we talked about before, hit 4 is when these immune complexes travel through the blood and get trapped in the glomeruli. It causes holes in the filter, and the protein leaks out into the urine. So on a kidney biopsy, we know that IgA is positive. It must be present in order to diagnose it. But there's also IgG antibodies, and there's also complement. Until recently, we mostly focused on the IgA. So what is this complement? Well, complement is a part of the immune system that floats through the bloodstream, and when it comes across bacteria, for example, it gets activated and really causes a snowball effect of both inflammation and destruction. So what happens is the complement is floating through the bloodstream inactive. When it hits something that activates it, half of the molecule calls out for more cells to cause inflammation. The other half goes and attacks a bacteria. It makes a hole in the bacteria, and the bacteria sort of bleeds to death. We do have things that keep this complement system in check. But when this complement system gets out of control, it can lead to a lot of permanent damage. Now, the thing that we're going to see is that these IgA and immune system antibodies that stick together in the immune complexes also activate the complement. They also get the complement to call for cells to make inflammation and try to make holes in the immune complexes to try to destroy them. So like I was saying, as it's traveling through the bloodstream, complement attacks these complexes, the immune complexes of the antibodies. And not only in the bloodstream, but also after these immune complexes have been stuck in the filter, the complement continues to attack them. These attacks lead to calling in more cells to cause inflammation, and the complement tries to destroy these immune complexes by making holes in them. This leads to a lot of inflammation and eventually permanent damage that makes holes in the filter and leaks protein out into the urine. The GLP-1 for kidney disease is exactly like I said. We know that it works in people with diabetes. We're not sure exactly what the mechanism is, but we suspect that people who have kidney disease with protein in the urine would benefit from a GLP-1, even if they do not have diabetes or obesity. We're waiting for the research trials to prove that. All right, so what is iptacopan? Iptacopan is another medicine that was published after the 2025 guidelines were published. What does iptacopan do? Well, it helps to block the complement system. It tries to block the complement system from causing all of this inflammation, from causing the holes in the immune complexes that then lead to inflammation and permanent damage. Iptacopan was studied in a trial called APPLAUSE, compared to placebo, 38% reduction in the protein. We're still waiting for the GFR data. So right now it has accelerated approval based on its 9-month decrease in proteinuria, and we're waiting for the 2-year kidney function data for confirmation. This medicine is also in a REMS program, a safety program, but for different reasons. Because this medicine blocks complement, and complement is a very important part of the immune system for certain bacteria, you need to get vaccinated prior to starting this medicine, or you actually need antibiotics until the vaccinations kick in. So we don't actually know what the benefit of iptacopan is based on the C3 deposits. There are many people who suspect that the more C3 on the biopsy, the more active complement is in causing disease. There has never been a study that sort of tried to tease that out or prove it. And the biggest problem is that people don't have fresh kidney biopsies by the time they go into these large IgA trials. So a lot of people actually ask me, Chevalier, what is your exact regimen? So because of medical insurances, I pretty much always start with ACE or ARB. If there was no medical insurance restrictions, I probably would start with the sparsentan since it beat an ARB in head-to-head trials. In any case, I do add on the SGLT2 if they still haven't met their goal, add it on to the ARB. And then if they're still not at goal, then I exchange sparsentan for the ARB and I continue the SGLT2. At the same time, I'm using whatever blood pressure medicines necessary to try and get them down to goal. All right, so now let's talk about the medicines that lower the galactose deficient IgA. So we've talked a lot about prong 1, decreasing the stress on the kidneys. Now we're going to talk about prong 2, lowering the galactose deficient IgA. The whole idea is to stop the body from making these bad IgA, and that will lead to less inflammation in the kidneys and hopefully calm everything down. Now, the 2025 guidelines only gave us 2 rough options. Since the time of the guidelines being published, there is another medicine on this side that now has been approved by the FDA. So number 1 is Nefecon. The KDIGO guidelines call this Nefecon, but it's really the budesonide. This medicine is marketed as a targeted release steroid that's only supposed to act at the Peyer's patches. This is some lymph nodes in the gut where it's thought that bad IgA is made. I looked up a lot of the things that have been marketed about this medication, and it actually is absorbed and goes through the liver vein to the liver. And then 90% of the medicine is supposed to be removed, and 10% continues systemically. So I have had people that got a lot of the same side effects as the systemic steroids. I actually think that the side effects are much higher in real life than are reported and marketed. All right. It was studied in a trial called the NefLigard study, and it did show that it lowered the bad antibodies. It lowered proteinuria by 27%, and it did show a decrease in the loss of the kidney function. Interestingly, the KDIGO guidelines suggest that one 9-month course might not be a cure, and that you might need multiple courses of this, steroid medication. Ironically, the systemic steroids are condemned in the same guidelines for needing more than one course because they don't give you lasting remission after one course. All right, number 2 in the guidelines is the systemic steroids. These are probably the ones that you're more familiar with, most commonly prednisone. They do not target anything specifically. They travel through the entire body and calm everything down. I think that they may get a worse reputation than they deserve because the trials that are always quoted are ones that used extremely high doses of prednisone and methylprednisolone, these steroids, which we would never use as a practicing nephrologist. I do think that steroids work very well in the lower doses that a lot of practicing nephrologists use. All right, we're going to shift gears for a second here. So someone asked about immunosuppressant increases the risk of infection, how to find the balance in preventing relapse and revising kidney function. Well, vaccines can trigger relapses of IgA, unfortunately, but I still think the benefits of most vaccines are greater than the risks. I do think that you have to balance immunosuppression versus infections. Most of the new medicines that we're going to talk about are way less immunosuppressive than the 2 that I've just mentioned. Stem cell therapy, I don't think we should talk about in this particular lecture. I think that's beyond the scope of this lecture. I'm not sure that it's going to actually be available in many years for IgA. It is being tested in some other autoimmune diseases. Yes, the person says that they tried the Nefecon, they got the moon face, they got the acne, the high blood pressure. I think that many people in my personal experience have had the same experience as the person in the chat, that the moon faces, acne, and blood pressure are extraordinarily common with the budesonide, the Nefecon, and that when they market as having fewer serious adverse side effects, they say that they had fewer hospitalizations for infection than the super high doses of prednisone used in one of the trials. They counted, the company that makes budesonide counted moon faces, high blood pressure, acne, all as mild to moderate side effects, and therefore did not list them when they compared them to steroids. Many people say the same thing as the person in the chat, that the low dose of prednisone gives them fewer side effects than the budesonide. All right, April. April is more than just the 4th month of the year. So April and BAFF are 2 chemicals that sort of make the immune system make more of these galactose-deficient antibodies. We know that April and BAFF are both elevated in people who have IgA nephropathy. We already have one April inhibitor that is FDA approved, and we might soon get more, including April BAFF inhibitors and or plasma cell antibodies. So what exactly are April and BAFF? Well, April stands for aproliferation-inducing ligand, but we just call it April. BAFF stands for B-cell activating factor, but we just call it BAFF. April works a little bit more on plasma cells, but also on B cells. BAFF works a little bit more on B cells, but also a little bit on plasma cells. They do overlap a little bit. Chevalier, where did they come up with this April and BAFF? Well, the answer is they did the genetics. So somebody asked earlier about genetics. They took more than 10,000 people with IgA nephropathy, and they looked to see which genes were mutated. One of the genes that came up as being mutated was APRIL. Another gene that was frequently mutated was called TACI, which is where some of these medicines, or kind of all of these medicines in this class, are going to work at least partially. The gene for BAFF, interestingly enough, was not mutated, even though both APRIL and BAFF are elevated in people with IgA nephropathy. So researchers studied both APRIL and BAFF. Pharmaceutical companies developed medicines to prevent or block APRIL and BAFF. Now that we have some anti-APRIL and anti-BAFF medicines, we actually know that the risk of infection is not that much higher compared to placebo. These medicines did their clinical research trials in the era of COVID, and the incidence of COVID was not statistically significant higher. So I'm actually very encouraged about this class of medicine. Once again, APRIL works more on plasma cells than B cells. BAFF works more on B cells and plasma cells. The question about APRIL and BAFF, the answer is coming up in a second. So I have sort of said, without trademarking anything, that these BAFF and APRIL are kind of like these live long and prosper cells. APRIL, for example, tells the plasma cells to live longer than they should. Plasma cells are supposed to make antibodies that fight infections. If this APRIL is too high, it keeps plasma cells alive well after the infection is gone. Unfortunately, APRIL also keeps the galactose-deficient IgA plasma cells alive much longer than they should be. If we can block APRIL and or BAFF, we should lower hit 1 galactose-deficient IgA antibodies and hit 2 antibodies that fight these. That should be good. Now, there is a chance the good antibodies could be too low, and it's also possible these medicines could work in other diseases that are caused by antibodies. All right, sibeprenlimab is a medicine that was FDA approved to treat IgA that works by blocking APRIL. Like we said before, APRIL works more on plasma cells and prevents the plasma cells from living too long. This is a shot that you give yourself under the skin every 4 weeks, and it does lower the bad galactose-deficient IgA antibodies. It was studied in a trial called Visionary, and it did reduce both the APRIL and the galactose-deficient IgA. It lowered 51 to 54%. They gave the protein in the urine less than 0.5, and as you can see, it was a little under 3 times as much as placebo. This is the first medicine in this class of B cell modulators, these APRIL and BAFF inhibitors, to be approved. I am hoping that with this new class of medications, that I may never need to prescribe steroids ever again. So there are very few side effects, and there's no safety program. The eGFR slope data for sibeprenlimab will come out after the trial finishes 2 years. So every medicine that we're seeing gets their preliminary, or what's called accelerated approval, after they show that they improve the proteinuria. They then get their full FDA approval after 2 years, and they show that the GFR is better. Currently, the only 2 medicines that have full approval are sparsentan and the budesonide, Nefecon. Sibeprenlimab, iptacopan, and atrasentan, as of today, still have their accelerated approval. The atrasentan 2-year data has been published, but it has not yet received its full FDA approval. All right, what's coming up in the future? So I've added a few things to the bottom of my guidelines, which are currently in development and might continue to be added to the guidelines. All right, so somebody asked the question about APRIL and BAFF. We are going to talk about that. So there are some BAFF-only inhibitors. One is already approved for lupus and was tried in IgA. It failed. Another one that's BAFF only was also tried in IgA. It had very little effect and failed. All right, there's one more APRIL inhibitor that's currently in development. It does not yet have its 9-month proteinuria data available. There are 3 APRIL and BAFF inhibitors that are currently in process. One of them, the atacicept, has published their 9-month proteinuria data, as you can see on the right. The other 2 have not yet published their 9-month proteinuria data. It is possible that the atacicept might be approved in the next 4 to 6 months. It's possible that the povetacicept might be approved by the end of the calendar year. All right, so here's the question that everyone's been asking. How important is BAFF? So BAFF-only inhibitors do not work. The gene for APRIL was mutated. The gene for BAFF was not. The only phase 3 data that have been published so far is one for APRIL only and one for combination APRIL-BAFF, and they are literally identical. So the big question that somebody asked earlier is, does blocking BAFF just suppress the immune system more? Does it actually improve outcomes? And only time will tell. Now, the other question that was asked was, how long are we going to take these APRIL and BAFF inhibitors? Many of us know that after steroids, many people with IgA can stop their immunosuppression and they remain in remission. We don't know yet how these APRIL and BAFF inhibitors are going to fall into that immunosuppressive category. When will we stop them? Will we decrease them? Those are all questions that are being developed, or answers to those questions are being developed. Another class of medicine with 2 medicines currently in study, they actually are antibodies against the plasma cells, which then would stop the plasma cells that make IgA antibodies and the antibodies that fight them. Again, it would actually work on all the antibodies, so we have to watch for all the plasma cells. We have to watch for low antibodies. No data, no results yet. There's also several studies being done on additional complement inhibitors in the same class as the iptacopan. So far, data not yet available. And last but not least, let's summarize and ask a few questions. So here's our patient, 32-year-old, newly diagnosed with IgA. GFR 70, blood pressure 135/85, proteinuria 1.8 grams per day, and the MEST C-score you can see there. So what was the old way and what's the new way for treating someone like this? Well, the old way is that you would start the ACE or ARB, use it for 6 months, then decide maybe steroids, maybe not. The new way is that we start something right up front. Simultaneously, we're going to start ACE or ARB or the sparsentan and one of the medicines that lowers galactose-deficient IgA at the same time. In the first few months, we're getting the ACE, ARB, sparsentan, SGLT2 up to the highest tolerated dose in order to try and get the protein in the urine down. Hopefully by 6 months, we can get the proteinuria down to 300 milligrams a day or less with both the immunosuppression and our supportive medicine. Here's a quick summary. Old way on the left, new way on the right. It's not benign hematuria. It's a progressive and serious disease. Do not wait for 1 gram to biopsy, half a gram with any suspicious features for inflammation. It's no longer get them under 1 gram. We want them under half a gram, ideally less than 300 milligrams a day. No more supportive care first and wait. Supportive and immunosuppressant simultaneously. It's no longer watch and wait. It's treat until you get to target. Now, one of the questions, there were many questions that were asked during the registration. I tried to put those answers into the talk itself. But one of the biggest questions was, Chevalier, can you talk about the 5 approved medicines and can you use their brand names? I know that we usually only use generic names, but because of the request, I've made some 5 multiple choice questions here to tease this out. So, question number 1. Go ahead and take your guesses. There was a question about whether people with less than 500 milligrams should try some of the newer medicines like an APRIL inhibitor. In general, we're not recommending additional medicines for people that are at goal. It's probably not going to give you a lot more benefit if you're already at goal and you don't really want to increase chances for side effects. All right. So the answer was the Tarpeo down there, the Nefecon or budesonide. All right, which of these medicines is a supportive or foundational medicine that's exchanged for the ACE or ARB? Go ahead and you can put your answer in the chat. I think you all did a really good job of listening because you're all doing extremely well on these last 5 questions here. So the answer is, in fact, Filspari, generic name sparsentan. All right, which of these FDA-approved medicines is a complement inhibitor that requires vaccinations prior to starting? Go ahead, you can put the rest of your answers in the chat. I actually think that everyone is doing extremely well. The answer is Fabhalta, the iptacopan. All right, which of these medicines is a supportive foundational medicine that's added to the ACE or ARB to lower medicines? All right, I think you're all paying very good attention because the correct answer is, in fact, atrasentan or Vanrafia. And finally, which of these FDA-approved medicines is an APRIL inhibitor that lowers galactose-deficient IgA? Well, for those of you that are keeping track of which ones we've already mentioned, the only one left is, in fact, sibeprenlimab, the Voyxact. All right, so this is my summary slide. The KDIGO 2025 guidelines: diagnose and treat earlier. Treat, simultaneous approach right up front. We are going to go for less than half a gram and ideally less than 0.3 grams. Now, the only thing that I'm going to say is people asked me for a lot of opinions on what I thought of each of these medicines. So I actually think that the iptacopan down here actually is more on this galactose deficient lowering or the immunologic side than it is on the supportive care side. I do think it might be both, to be honest, but when I've tried using it as either immunosuppression or as like a supportive care, I find that it does a little bit more as the immunosuppression. There are people that are starting to like put it on the immunosuppression side rather than on the supportive care side. But like you saw earlier in its mechanism of action, it probably would do a little bit of both. And like we said, this is a lifelong disease. We want to protect the kidneys for decades, not just for a few moments. Oops. So I do want to give a few thank yous here. So a lot of people helped me develop some of my thoughts for the slides. I do want to thank Julie and Kapil because they supported today's presentation. And then if you'd like some personal education or if you have questions or would like an appointment, you're welcome to call. I don't know if we're going to use galactose deficient IgA as the new biomarker. I've wondered if like the future 2030 IgA guidelines are going to tell us to get the galactose deficient IgA under some number. We know that every person, even healthy people, have a little galactose deficient IgA, but they don't have all 4 hits, so they don't get IgA nephropathy. Some people think that it's going to be a little too hard to use as a biomarker because it's a finicky test, and there may be other things that are better. Iptacopan and April, probably not using both. I don't know. I think that we have no data on combination therapy, and we probably never will because each pharmaceutical company is probably unlikely to like use another pharmaceutical company's product in their tests, especially not head to head. I do wonder if experience or like people who treat a lot of IgA are going to share their experience. I know that I've done a lot of combinations. I feel comfortable using Filspari plus SGLT2 and even plus iptacopan together. I've done that a few times and I have not seen a lot of side effects. I pretty much have used the sibeprenlimab now in a lot of the people who have uh, tried everything on the market and still were above their proteinuria goal and were just waiting for something new to come out. So I feel very comfortable using the sibeprenlimab with the sparsentan and the SGLT2 inhibitor. So I do think that as time goes on, we're getting experience with these combinations. All right, I was going to let Christina or Jeff or anyone else, any of the other panelists, have a final thank you and a final closing statement.
Good evening, everyone. This is Christina. I direct the fundraising program and marketing program here at Rogosin. Thank you so much for joining. And I just wanted to add my thanks to Julie Lamb and Kapil Mathur for their amazing support tonight's program. And of course, a huge thank you to Dr. Chevalier, who's helped us bring the webinar to life, bring so much information out to help patients everywhere. Thank you, Jim.
Thank you.
All right. With that, if there are any more questions in the room, any things you would like to ask, we have a couple of more minutes before we wrap up.
So the trap degraders are still in research trials right now. I wonder how much they're going to be used if we already have things that lower the galactose deficient IgA. I do like that they work in a different mechanism of action, but they're still quite a ways from coming to market. So they're going to have to get through some research trials and prove their worth, and then see how they're going to be incorporated into the way people are already doing things by the time they come to market. So CD38 is an antibody to the plasma cells. If it's an antibody to the plasma cells, I suspect it may be sort of similar-ish to medications like rituximab or obinutuzumab, which sort of wipes out the B cells that become plasma cells, or similar to some of the multiple myeloma medicines that do wipe out the plasma cells. I expect that those antibodies will likely lead to lower antibody levels by wiping out the plasma cells. I also suspect it's going to be like those medicines that I mentioned before, where you're going to try to reboot the immune system the way that you reboot a computer and try to wipe things out. And then when they come back, we hope that the plasma cells that come back would only make the good antibodies and not the bad galactose deficient IgA antibodies. And thank you to everybody for all the kind comments in the chat.
Thank you, everyone. Have a great evening. The video will also be posted on our Rogosin YouTube channel and podcast site. Thank you, everyone.